Hi, everybody. Thanks for joining. I'm going to turn off the chat box now and just be sure to enter your questions into the Q&A. We are going to have a few questions on polling. Hi, everybody, friends from Pennsylvania. We are going to have a few polling questions. So if you're able to be at your computer to answer those, that would be wonderful to have everybody's input. They're clinical questions. So we're going to have a little challenge here. Okay, let's see. So today's December 1st. This is the Adult Cardiac Surgery monthly webinar. On the line with me, or on the Zoom call with me from STS, I have Addie Dolan and Melinda. Leanne is off today. And then from IQVIA, we have Jean, Joe, and Steve, and Melanie will be joining us a little bit later. So thanks everybody for joining. I hope you had a really nice Thanksgiving, got to spend time with family and friends, and enjoyed being with one another this year. Important updates. We have our monthly webinar is today. December 15th is our next user group call. That's at 2 p.m. Central. And Melinda will be having a discussion on a failed TAVR. Usually we save our discussions or education for the monthly webinar, but because we have something educational for this webinar, and we don't have a webinar in January, a webinar in January. We'll have a user group call in January, but because we don't have our monthly webinar for educational purposes, we're going to have that instead on December 15th. So be sure to join because it's more common in the database now, and Melinda has a lot of great information to share on that. December 17th, that's when Harvest 4 closes with OR dates through September 30th. Harvest 4 opt-out ends on December 21st. And January 19th will be the January user group call at 2 p.m. Central Time. The Harvest for 2022 dates have been posted. They're on the STS website under additional resources on the national database page. I'll let people take a screenshot if they want of that, but I'll show you where it's at as well. Quick STS updates. Don't forget that AQO is available in the STS Learning Center. And if you have any questions with that, you can reach out to me and I can put you in touch with somebody or whomever can help you with accessing the Learning Center. It is the same login information that you use to log into the AQO platform this year. So I will show you where that is at as well in just a few minutes. Harvest 3 data is back from analysis. That's the OR dates through June 30th, and that will be a star rating report. It is at IQVIA. They are preparing for release. It just finished up testing with some beta testers, got good feedback, no issues, and we're aiming to release that report on Monday, December 6th. So it should be released over the weekend. And I will send out, STS will send out official notification after the release is posted to the sites. So keep an eye out for that notification. November training manual is posted, and Melinda's working on the December updates. Now I'm going to hand it over to Joe. Joe.
Great. Thank you, Carol. Good afternoon, everyone. I do have a few updates, an upcoming release to announce today. So the items I'm about to mention are going to be released on December 18th. So that is in a few weeks. So starting with some issues related to the participant dashboard report, the non-analyzed report, STS 6747. When reviewing the participant dashboard report, users were finding one value displayed in the online report and then a different value displayed on the same report when it was exported to Excel. So we did identify what was going on with that, and we do have a fix ready for the 18th, so that should be resolved shortly. STS 7175, a similar and related issue to 6747 that I just mentioned. The graph data at the top of the dashboard is also showing a different value when it's exported to Excel, and it's the same root cause. So the fix for the previous item I mentioned will also resolve this issue with the graphs, and so those will both be corrected on the 18th. STS 7173. When you attempt to select multiple rows, so if you were to shift click or control click rows on the report to select multiple, that will currently give you an error and it will not work as expected. And that should be fixed on the 18th so that you can then begin to select multiple rows if you'd like to. Moving on to the risk adjusted, the analyzed report, STS 6706. There is currently an inconsistency with the display for the attending anesthesiologist medically directing CRNA variables that appear under the care team model section of the anesthesia report. The My Site section for those values is not pulling in the data that it should be, and so that will be resolved on the 18th. STS 7183, the blood products calculations in the benchmark reports for 2020 will be updated to remove the intra-op blood products refused parent field, as that is no longer applicable in version 4.20.2. And then finally, STS 7246, when looking at infection complications on the benchmark reports under morbidity and mortality, no data is currently being displayed for the like group and STS aggregate for the deep sternal infection, mediastinitis, and conduit harvest or cannulation site lines. The cause of the issue has been identified, and that will be resolved on the 18th as well.
Great. Thanks, Joe.
Yep, no problem.
I see Heidi put this in, and I know we've been talking about it on our elaboration calls about the post-op pneumonia to be displayed in the dashboard. Do you have a timeline or a timeline on that, or would you be able to check to see? I know that we talked about it and it's coming. I just don't know if we have it. It's not slotted for this release, but is it slotted for one of the next ones?
I can look, unless Steve knows. Melanie unfortunately was not able to be with us on the call today. She would be the best person to answer that, but I can look and see if I can get an answer for Heidi.
Okay, thank you.
Mhm.
Okay. All right, next slide. Oh, known issues. Don't forget that IQVIA will post an updated version of the full list of known issues and enhancements to the library for user reference. And then if you're submitting tickets that are submitted tickets are currently under review, and the IQVIA support team will follow up in resolution and or target release confirmation. And they're currently reviewing items that will be released in upcoming releases. Those items will be posted to the notification section as well. And we have elaboration calls with IQVIA weekly to go over suggestions that come in from you all, from the data managers, and things either that you would like to see, or you would like to see a different way, things like that. We have a lot of communication with them, and we kind of have to prioritize updates. The pneumonia one is a higher priority item, so I know that it is coming, but we had to slim down some of our suggestions just so we could get things out instead of waiting for everything to be done at once. So those types of issues are under review at IQVIA and with STS as well. Okay, everybody get their polling fingers ready. This is going to be related to, I think we have 6 questions. It's going to be related to the November training manual updates. And these were some of the ones that I thought were most important to the largest group of people. So the first one we're going to talk about is for the medication for the beta blocker medication sequence 1030. The question is I have an elective patient who is on a beta blocker at home. There is no medication reconciliation done the morning of surgery. If the surgeon or anesthesiologist document that the beta blocker was taken within 24 hours of surgery, can pre-op beta blocker be coded yes? So I'm going to launch the poll here, and I want to see what you all think. And the answer is this. The choices are no, there is no clear documentation that this medication was taken, or yes, there is clear medication documentation that the medication was taken within 24 hours. So I'm going to let this run for a little bit, and then I'll show you what the answer is, and I'll let Melinda talk about it. We have a little discussion about it. And the reason why I thought, and the polling results are kind of what I thought we'll see the next question too is similar But these ones are tricky, and that's why we provide clarification. That's why Melinda provides clarification in the training manual on these. Okay, I think we got pretty good response here. All right, I'm going to end the poll and I'll share the results. So 22% of you said no, there's no clear documentation that this medication was taken, and 78% said yes, there's clear documentation that it was taken within 24 hours. So Melinda, the answer is?
So we actually presented this at AQO too, but I'm still getting a lot of questions about it. So we're going to kind of run through this again. So you have an elective patient who is on a home beta blocker. They come in and there's no medication reconciliation done, but the surgeon or the anesthesiologist document that the patient did take their beta blocker within 24 hours of incision. So in this particular situation, you can code yes, that the beta blocker was taken because you don't have any other documentation of the pre-op beta blocker in this medical record. And there's no conflicts in the medical record that it might indicate that this documentation from the surgeon or the anesthesiologist is not true. So in this particular situation, you can say yes. Now, and I just had a question this morning in my mailbox, if this patient is an inpatient and the anesthesiologist checks the box, the beta blocker was given, but there's no record of a beta blocker in your MAR being given or on the anesthesia record of it being given or anywhere you can't find that this beta blocker was given and this patient's an inpatient, then you have a conflict. So who's telling the truth, right? So then you have to clarify, and you can't automatically just code it based on the documentation by the anesthesiologist if the patient's an inpatient.
That's right. That's good clarification. That's two different groups, right? You have an outpatient and you have an inpatient.
Right.
So the outpatient, we're not going to use the med reconciliation as the only source of truth. You could use other documentation from the surgeon or anesthesiologist.
Well, in this particular case, the patient didn't have no medication reconciliation.
No, that's what I'm saying. If they didn't have that, so you don't use the med reconciliation from the whole medication list. You could use documentation, like you said, from the anesthesiologist or the surgeon.
You can, but now if you did have a med rec in this patient, and there was a conflict, again, you'd have to clarify. If the med rec said the beta blocker was given 2 days ago, but the anesthesiologist is checking this box that says, no, it was given in 24 hours, well, that's a conflict. So you have to clarify.
Okay, and Elizabeth says, your question says within 24 hours of surgery, not incision. So I would think that would be a no, because surgery and incision are two different times. Oh, I see. Because the question says 24 hours of it. What does the data?
Semantics. It's semantics, Elizabeth.
Yeah.
Don't worry about it.
Thank you, Melinda.
It's incision if you read the answer, taken within 24 hours of incision. So it's just a typo, semantic typo.
Okay, thank you. What if the documentation's not by a surgeon, but by a pre-op RN or somebody else caring for the patient?
Well, I think if, that's a different situation, you have to look at it. Is it a checkbox? Is it her nurse's note saying she interviewed the patient and they took their beta blocker? Is she doing the med recon? I mean, you kind of got to look at everything when you look at these situations. So I think if the RN clearly documented, the patient told me she took her beta blocker this morning, then yeah, you could use that for sure.
Okay. And Heidi, I'm going to skip over your question right now. I'm going to go down to Carrie's question because I think this is a good one. And then we're going to go on to the next FAQ. She says, if the patient was seen in pre-admit by nursing for teaching instructions, and it was documented for the patient to take the beta blocker the morning of surgery, could this be counted as yes?
No,
I agree.
because just because you instructed the patient to take the medication does not mean that they followed the instructions. So.
Right. Totally agree with that. Okay. And Heidi, we'll get to your question in just a few seconds here. All right, I'm going to go on to the next FAQ. So get your polling fingers ready. And this is where it gets tricky, right? Because we have this answer here, but wait for the next question because you got to think about it a little bit differently. No. Okay, sorry. Medication for beta blocker sequence 1030 again. If the patient is on a chronic home beta blocker therapy and that medication is listed in the pre-op H&P medication list, but there is no documentation of the last dose, date, and time that the home medication was taken prior to surgery. This is including all the surgeons and anesthesiology notes and all of that stuff. Is it acceptable to code yes for sequence 1030? And here's the poll. Your choices are no, there's no clear documentation of the last dose taken, or yes, since it's a chronic medication, it's safe to assume the patient took the medication within the last 24 hours before surgery. And we'll let that run for a little bit. This is why things get so gray, Melinda, isn't it? We can't have black and white.
It gets real gray.
Yeah.
That's why every situation is a little different.
Mm-hmm. Okay, I'm going to stop the poll. We got a good response right here, and I'll share the results. 91% said no, there's no clear documentation of the last dose taken. 9% said yes. Since it's a chronic medication, it's safe to assume the patient took the med within the last 24 hours before surgery. All right. And the answer is?
The answer is no.
The answer is no.
The answer is no. You have to be able to prove that the beta blocker was given within 24 hours of the incision. So in order to do that, you need to have you can have several things. You can have a date and time on a med recon that says this is when it was given, or you could have clear documentation that we just talked about in the last slide. If you don't have a med recon and the only documentation you have is the surgeon or the anesthesiologist is saying, yes, they took it within 24 hours and there's no conflicts. Or you could have a note by the RN that we sort of talked about in the last few minutes, saying, hey, the patient took this beta blocker with a sip of water this morning as instructed. So you got to have some proof that it was given within 24 hours. That's the key here, because this is a timing. This is not whether this is a timing issue. So we have to know whether it was given within the 24 hours prior to the decision.
Yeah. Thank you, Melinda. And Linda said, wouldn't you select unknown? But for this question, there is no unknown. It's yes, no, or contraindicated.
There's only unknown for the 2-week beta blocker, not this one.
Right. Jessica's asking, sometimes our EMR says still taking as prescribed, but does not list as a last dose date and time. How should that be coded?
No, because you can't prove that it was given within 24 hours.
Okay. And then would it be appropriate to have anesthesia document time? I think that's okay. They do their
well, you can, and sometimes some hospitals even have anesthesia give a little dose of beta blocker before the incision.
That's right. Yeah. And that's something Carolyn then says, we have addressed this issue by having anesthesia administer a beta blocker in the OR before the incision if there's no clear documentation stating that the patient took the beta blocker. So that's exactly what you were saying, Melinda. And I have a feeling that's happening at other sites as well. That's good info. All right. And then I don't know. Oh, I should have stopped sharing. I hope that wasn't filling up your screens the whole time. And then here's a question in regard to the beta blocker. If pre-op H&P states patient is requested to take aspirin, beta, and statin prior to surgery and discontinue anticoagulants 5-day. Oh, and this is Heidi, this is what Melinda had just answered for the other person. Sorry, I didn't read your question earlier. In regards to beta blocker, pre-op H&P states patient is requested to take aspirin, beta, and statin prior to surgery and discontinue anticoagulants 5 days prior to surgery. Can we use that to document that the patient took it? And that was the same. That's no, you can't assume. There has to be clear documentation. Okay. Thanks, Melinda.
Okay.
Is it acceptable to document contraindicated if anesthesia states not on beta blocker pre-op?
Well, okay, so I get this question a lot. And first of all, I understand that there's a little disagreement out there in the literature with anesthesia literature versus some surgical literature that say the beta blockers doesn't do anything. Okay, so I know the literature's out there, and I know that there are some anesthesiologists that are pushing this issue. So, but what I will say to you is that for now, pre-op beta blocker in cardiac surgery, CABG patients, isolated CABG patients is a NQF measure. And it's expected that the patient will be given the beta blocker, or there's a medical reason for not giving the beta blocker. So with this documentation, anesthesia says not on beta blocker pre-op. Well, so why is the patient not on the beta blocker pre-op? Okay, yeah. So is there a medical reason for that? Or, so I mean, that documentation in and of itself is, I would not say contraindicated, because it's not telling me why. It's just stating fact.
Yeah, I agree with that. Okay, good. And then one more question on beta blockers. This one's regarding the 2-week therapeutic levels. And then we're going to go to the next FAQ. So last question on beta blockers. In the case of the question of the patient, if the patient has taken a beta blocker for the last 2 weeks, is it okay to assume that they are on home therapy? In the case of the question whether the patient has taken a beta blocker for the last 2 weeks, it is assumed if they are on home therapy that they have, correct?
Yes, yeah, that's correct. If they're on home therapy, it's assumed that they've been on it for 2 weeks.
Right. Okay. All right, next FAQ question.
We've got a couple more beta blockers here.
Okay. When is the implementation date month of this updated beta blocker 1030?
Oh, that was just in November. Came out in November.
Yeah. Was it a significant change, Melinda?
No, it was not a significant change. I think that it's just a clarification because
yeah,
we get so many questions about it. I think it was I just put it in there because I kept getting so many questions about this. And the key really is the 24 hours. So if you got some clear documentation that it was given within 24 hours, then you can count it if there's no conflicts in the record.
Okay, thank you. And then next one, so we can assume per sequence number 1035 about beta blockers, just not whether the 24-hour prior to incision question.
Right. There are two different beta blocker questions. There's one that shows whether they got it within 24 hours. That's 1030. That's the metric question, the NQF measure. And then the second question is the beta blocker therapy for 2 weeks, which is really, the intent really is to capture use of anti-anginal medications in patients and are physicians appropriately prescribing the medications that they need to. So those 2 week questions for it's the beta blocker, the anti-anginals. I can't think. There's another one, I think, but those are really like and Renexa. You're trying to find out how these patients are being managed at home. So the intent of the two questions is very different.
Mm-hmm. That's right. Okay, thanks. And then just a comment, I worked with the clinical team. This is from Sharina. I worked with the clinical team, providers and nurses, and educated them why it was important for the patient to get the pre-op beta blocker or at least document the contraindication. Now the team monitors their own compliance and I don't need to chase them anymore. And I think that's right. I think that's wonderful. I think it just takes a little effort on the upfront to get everybody on board. And then it sounds like you got buy-in from them, which is really nice. Good job. Wouldn't you look at the medical records to make sure the start date had been at least 2 weeks prior?
Well, Debbie, I think if you have that available, you surely can if you like, but a lot of times you don't have that kind of information available in the medical records for these patients.
Yeah. Okay. Next question. Debbie says, thank you. Next question. Get your polling fingers ready. Should thymectomy at the same time as CABG be abstracted in sequence 2155, which is other non-cardiac procedures? Is this a trick question? Let's see. So your choices are no, it definitely should not be captured. Do not code this procedure. It should not impact the case if it's analyzed or not. Yes, of course, it should be captured as other non-cardiac cases should not be analyzed. Yes and no. Yes, if removed completely for a specific disease, such as myasthenia gravis, or no, if partially removed as part of the cardiac procedure. Tricky. So let that run for a little bit. Melinda, this was a good FAQ.
I know. I get this question a lot.
Yeah, and I think it's good to talk about it because it's one of those areas where we just have to see what's really going on with the patient and what the surgeon's doing in the operating room and for why.
Mm-hmm.
So you really get to know the patient's history. Okay, I'm going to stop that. All right, and it looks like 14% said no, not to code it. It shouldn't be analyzed. Oh, it should. No, it should not be captured. Don't code the procedure because it doesn't. Because it should not impact the analysis. 17% said yes, of course it should be captured as other non-cardiac, which means the case would not be analyzed. And 68% said yes and no. So Melinda, what's the answer?
The answer is yes and no. It depends. So first of all, the thymus can be removed in part during any cardiac surgery. And in fact, in the old days, they took the thymus out all the time before they realized that it was actually a good little organ to keep in there. And it's not coded. So you don't code it if it's just removed incidentally. If it's removed for a specific disease process, it's removed completely. This patient has myasthenia gravis. They're having issues. We got to take this thymus out. Then you can code it as another non-cardiac procedure, because then you run the risk of, the thymus is clearly diseased at that point, and that does add risk to the surgical procedure. A non-diseased thymus that's just taken out incidentally, and by the way, that used to happen all the time, and does not get coded at all.
Good. Thank you. Thanks for explaining that. All right. Another non-cardiac question. My patient had a CABG and the case included a vascular surgeon performing a carotid endarterectomy during the same surgery. Do I still code other non-cardiac procedure sequence 2155? And I will launch this. So let's see what you have to say. The choices are no, do not capture the carotid endarterectomy for 2 reasons. It was done by another surgeon. I was supposed to say surgeon, not surgery. And it has no impact on the CABG procedure, or yes, this should be captured as other cardiac on the same DCF. It doesn't matter if it was done by a different surgeon, it impacts the CABG procedure with risk and analysis. Let's see how that goes. I hope you all like these polling questions. If not, let me know. We'll never do them again. But I think they're kind of fun to see how all you all are thinking with one another. Okay, let's see. We're going to end this poll. And Melinda, okay, so let's see. What did everybody say? People said 9% said no, not to capture it. And 91% said yes, of course you should capture this as other non-cardiac. Melinda, what's the answer?
Yes. So let's talk about this a little bit. So I think what hangs people up on a situation like this is that the carotid is being performed by a different surgeon. And so they're like, oh, this surgeon's not on the participant agreement, so we shouldn't even put whatever he does in this database at all. But what you have to look at is the CABG is being performed by a participant surgeon who is also at this very same time and vascular surgeons operating on the carotids. Now, think about it. That carotid surgery is going to add risk to that CABG and could have a bad outcome from the carotid surgery. So it's really important in this situation to code that carotid endarterectomy as another non-cardiac vascular procedure because it adds risk to the CABG and it will remove the CABG from the isolated category. I mean, just imagine if you didn't code it and the patient died.
Or had a stroke, right?
Or had a massive stroke.
Yeah.
Which is probably from the carotid.
Right.
So anyway, now we have a great list of stuff to code and what not to code as far as non-cardiac surgery goes in the training manual. There's a lot of things we don't code, but a carotid endarterectomy is definitely one we would code because it adds significant risk to the CABG.
Ooh, here's a good one from Donna. How do you code the carotid disease prior to the CABG then?
Well, you code the carotid disease because
let me pull up the, I can pull up the DCF and we can talk about that if I can figure out how to make my screen smaller.
Well, I think I can just, but I would say you would just code the percent of the stenosis of the carotids because they're not operated on yet and they're going in with disease.
Mm-hmm.
There it is. So it's under sequence.
I know what I passed.
Wait a minute. I should know this. 345 or something like that. I don't know.
It's up here under the
Close.
preoperative stuff. Oh, dear Lord.
Oh, Lord.
Slowly. There we go.
Oh, 545. I was close.
It's okay.
I knew it had a 45 in it. Okay, so you would say yes to cerebral vascular disease. And that's 525. And then you do your carotid stenosis. And whether it's right, left, but both, and then you do your percent of stenosis because the patient's going into the operating room with that disease.
Right. And what about 560 history of previous carotid artery surgery and or stenting?
No.
Okay.
Because they don't have a history of it. They're going to have it during the CABG.
Mm-hmm. Okay. That sounds good. Thank you for clarifying.
Okay.
Hold on. Okay. All right. Thanks, Melinda. Next question. We have 2 more left, and then we'll get to the other questions that are coming in.
Okay.
Next question. If we have a convergent procedure, do we code the cardiologist's portion of the procedure, i.e., the other lesions involved in the procedure? No. So your choices are no, only captured the surgical portion of this procedure completed by the CV surgeon as epicardial posterior wall other, which is how we define convergent procedure, or yes, you need to capture the entire procedure. So this goes, when we look at the procedure we just talked about where we did a carotid was done by the vascular surgeon. And then now we're going to talk about an AFib procedure done by both the EP guy or the cardiologist and the regular surgeon. This is where we get a little, why it's really important to read the training manual and to make sure as you're capturing these, to see what what kind of updates are in there, but also just, I think, don't assume that because we do one thing one way, that we do that consistently for everything, because a lot of nuances and reasons why we have to instruct to collect data the way that we do. And it has a lot to do with the risk of the procedures and what actually is done to the patient, so we get a good picture of that. So it can get a little hairy sometimes. Wouldn't you say, Melinda? Get a little confusing. We can't be
Well,
consistent.
It is, well, it's a little conflicting.
Yeah, it is
at times.
conflicting. I agree. Okay. Let's see. I think we got 50%. I think people are going into the FAQs and pulling up the cheat sheets. That's what's taken them so long to answer. All right, I'm gonna stop the polling here and share the results. And Melinda, what's the answer?
The answer is no, we're only going to capture the surgical procedure. And I know this sounds conflicting, especially by what we just about talked about, but this comes directly from the task force that's in charge of how we put this into the database, the surgeons that are on that team, and they feel like they only want us to capture the surgical portion of the convergent procedure.
Yeah, it's a little hard to articulate why we capture the carotid portion of a CABG with carotid done by two different surgeons, and why we don't capture the rest of an EP procedure done by a cardiologist or EP, and the surgical part of the surgeon part of the convergent procedure. I think it has mostly to do with a couple reasons. I think the risk of the carotid procedure and the CABG. I think that's really important to make sure that we aren't analyzing, or that we are analyzing apples to apples when we look at CABG procedures. So we don't want to include those cases that have the risk of a simultaneous carotid endarterectomy done at the same time as a CABG, because those patients are a different population than straight CABGs without a carotid. The other thing that we want to be thoughtful of is, we're always going to look at the risk first, and then we're going to look at other important things like what the CV surgeon is actually doing in the OR when we take risk out of the equation. So for this procedure, for the convergent procedure, we're not so much concerned about the cardiologist portion, the risk of the cardiologist portions of the procedure, but we're more concerned about what the cardiothoracic surgeon is doing in the operating room or wherever this procedure was performed. So it gets a little confusing, and I think Melinda does a great job working with the surgeons on this. So thanks, Melinda, because it is definitely confusing for folks, for me, I should say.
It gets me confused at times too. That's why I'm always in my training manual. I'm like constantly in my training manual.
Okay. Yeah, I am too. Okay. And I never assume, because I've gotten caught on that a couple times. So I really try not to assume. I shouldn't say never, but I really try not to assume, because I learn something every day from going into the training manual. Heidi has a question on the carotid topic. She says, she's curious how many places are seeing vascular teaming up with CV surgery to do the combos. And I don't know that I don't know that I have an easy way to look at that, Heidi, but if folks wanted to reach out to you and share that information, they certainly can. Or we can do a polling on that, but I can't do it right now. So I'll do that for you.
I actually think it's fairly common.
Yeah, I'll do that in just a little bit. And I guess it depends, right?
Yeah.
A lot of the times the vascular surgeons are the CV surgeons. So, it depends what your hospital looks like.
All right.
Okay. Okay. So the next question is, okay, so our convergent procedure patient gets moved from the CVOR to EP lab to finish AFib procedure.
Right.
So I just code the procedure in CVOR.
Uh-huh. Yep.
Thank you. And
that sounds weird, but hopefully you probably have two logs. You probably have a OR log and a cath log. So hopefully your times and stuff will be real clear and clean for you.
And then Jenny Anderson says, compared to the convergent procedure, how about the procedure when a CV surgeon does a lead extraction and EP is in the procedure and does a lead insertion at the same surgical instance?
Right.
Do you
Well,
capture both or just the lead extraction?
there you capture everything in that one. Because see, this is how complicated it gets. Probably the convergent is probably the one of the, I would say, one of the very few examples that we don't capture the whole procedure. Okay. I'll say that it might be the only example. Okay.
Mhm.
Or very small. Most of the time we capture the whole thing that's going on.
Yeah, I don't know why they had to change it on us for that one.
I just think they just, when I talk to them, they just aren't interested in they only want to see how, I think they just really want to see how many convergents are being done, and they don't want to muddy the data with whatever else was going on, and I think they want to see how many surgeons are doing convergence. So it's, I just got that sense that they just weren't interested for their data purposes into having the whole procedure put in for the convergent.
Yeah. Okay. We're going to go to the last one. This is a good one. Probably has happened. Hopefully it doesn't happen very often, but it's probably happened at quite a few sites. This is on the stroke and encephalopathy one. It says patient had a cardiac arrest post-op. The patient is unresponsive to verbal and noxious stimuli and is noted to have myoclonic jerks. Neural consult was requested. The neurologist did not provide the diagnosis of encephalopathy, but instead anoxic coma. Do I capture this event under encephalopathy or stroke? And your choices is clearly this is a stroke, coded as a stroke, or not all comas post-CV surgery are related to stroke. Some can be related to lack of oxygen or post-operative swelling in the brain. I should code this as anoxic encephalopathy, not as a stroke. Ooh, look at this. All right, everybody's getting their answers, and I just want to say thanks everybody for responding. We'll keep up with the polling questions. I like them, but just because I like them doesn't mean you all like them. So I'm glad you do. And I know Melinda likes them, right, Melinda?
Oh, I love polling questions. Always have.
Yeah, they're fun. Okay, got a good response rate. Give it a couple seconds here. All right, I'm going to end the poll. Melinda, and the answer is
no.
Nope.
So we actually had a really good conversation with the surgeons over this, because clearly the patient had some sort of massive neurological event, right? And after the discussion, and there was probably 6 or 7 surgeons on the call, they all said that they don't consider this a stroke. In their mind, this is anoxic encephalopathy. And so I know that in the past, I'm not saying I did it, but in the past, because I can search the FAQ mailbox. I know that there may have been some answers in the past that said, yeah, this is a stroke, but that's one of the reasons I wanted to get it into the training manual, and straight from the surgeons, that no, they don't want this captured as a stroke. This is to be captured as encephalopathy.
Great, thanks, Melinda.
Okay.
Okay. I don't see any questions specifically on this one, so I'm going to go back through the regular questions that came in. Let's see. Oh, I know. I want to go through this real quick again. So with the reports expected to come out this weekend, Harvest 3 data, I just wanted to remind you all of the timeframes and the thresholds that are being applied. Answer any questions on this. Unfortunately, I do have to go right at 3 o'clock Central Time. So if I can't get to the questions on this, I'll ask you to email me. But starting with Harvest 3, which is the data that's expected to be posted, the reports that are expected to be posted to sites this weekend, OR dates through June 30th of 2021. We changed the CABG composite from a 12-month to a rolling 36 months. So it will include OR dates from July 1st of 2018 to June 30th of 2021. We increased the confidence intervals from 98% to 95%, so wider confidence intervals. And then we changed the number of required cases to 50 over the 36 months. So it's total 50 cases during this 3-year time period, not broken up, not so many cases per year, but 50 cases over 36 months. The mortality threshold, so those mortality fields that we check to make sure we get the data complete, those are going to stay the same at 2% or less of missing or unknown. And then here's an example of what that means for harvest 3. And then we just scoot this down by 3-month time increments for harvest 4 and so on. For harvest 3, which again is July 1st, 2018 through June 30th, 2021. We have 3 12-month time periods within this reporting period. 7/1/2018 to June 30th, 2019, July 1st, 2019 through June 30th, 2020, and July 1st, 2020 through June 30th, 2021. Each of these time periods has to have 2% or less of missing or unknown for the mortality fields to be included in the analysis and to receive a star rating for harvest 1 and harvest 3. If you have greater than 2% missingness or unknown for any of these time periods, then you would be excluded from analysis. The NQF threshold stays the same at 5% or less for the rolling 12 months. The analysis will include the 3-year time frame, but the same idea is applied where we look at each 12-month period within that 3-year time frame to make sure that you are at 5% or less for missingness on the NQF measures, beta blocker, anti-lipid meds, discharge anti-lipid meds, discharge beta blockers, discharge lipid lowering meds, and the internal mammary usage fields. And then the other volume requirements. So for cabbage, it's 50 isolated cabbages within 36 months. For AVR or AVR plus cabbage, so aortic valve or aortic valve cabbage procedures, you have to have 10 isolated procedures to be included in analysis. For MVRR, so repair or replacement, it's a total of 36 procedures for that 3-year time frame, or 12. Yeah, for that 3-month. Oh my gosh. For the 3-year time frame. And for MVRR plus cabbages, it's 25 procedures for that 3-year time frame. When looking at mortality for the combination procedures, you have to look at the total missingness together. So for MVRR or plus cabbage, you have to look at all of these procedures together to get your total missingness. It's not broken down by each specific type. Okay. And then questions, you can email me, ccrone@sts.org, and I'll help with those. We're going to go through the rest of these questions here. Are you ready, Melinda?
Yes.
When a patient has a previous EVAR for a AAA, where do I code the past EVAR, possibly under 810 aortic procedure thoracoabdominal and 4510 previous repair zone 8, 9, and 10 and 11?
Yeah, that's correct. 810. We added an update in August of 2020 under other cardiac intervention not listed under sequence 810, and it includes infrarenal abdominal aorta procedures. And you have to, we had to do that because we were getting consistency error because we weren't coding it as a prior intervention, but in the aorta section, you were saying there was a prior intervention. Mm-hmm. So we were getting this consistency issue. So we had to fix that by updating sequence 810.
Very good. If a patient has a pre-op creatinine of 0.5 and a post-op peak creatinine of 2.2, this would qualify for renal failure. Is that correct?
Yes.
Mm-hmm.
It's 4 times, that's like 4 times your baseline. That's a lot. And the data definition is 3 times the baseline or greater than 4 with a 0.5 rise. So this
That's
is
right.
definitely greater than 3 times the baseline.
Lots of positive feedback on the questions, so I'm glad you all like them. Gail, you're trying to contact Elizabeth Watkins, but Elizabeth hasn't worked at STS for about 3 years. So I'm not sure exactly what it's regarding, but you could reach out to stsdb@sts.org if it's a non-clinical question. If it's related to operations, contracting, things like that, that's your best email to reach out to. A big concern is if these elements are going to be subject to audit, since there's so much debate in gray area. Just abstract, according to the training manual, I don't think these are audited.
Well, I was going to add to that. Things like that, probably those little tiny things like that we've talked about probably aren't, there's some things, not everything's audited, but everything that we're talking about is in the training manual. And the auditors go by the training manual.
Mm-hmm.
And if they have questions, they do seek clarification. So I think it's the most important thing is to stay in your training manual, because it updates every month. And most of the updates are clarifications, trying to make things clearer for people, more helpful. Sometimes I just added a couple pictures. I think Jacques asked me if I could put some pictures from AQO about the pedicle and the skeletonized IMA and the training manual, so as a visual. So a lot of times the updates are just to continue to clarify and make the training manual as useful as possible to the abstractors.
Thank you.
I saw Mary had a question, but where did it go? I don't remember. It had to do with the IMA. I read it.
Did I accidentally just remove it?
I think so. Is it
I didn't
the
mean to.
dismissed one? Let me see if it's in the dismissed one. No.
No, I know it's at the bottom. Oh, where did it go? Here, can you clarify why in sequence 2630 we code IMA when it's already coded in 2626?
Okay, so in 2626, we're asking about the IMA being used, right? And I know it sounds a little repetitious to go down to 2630 and say the distal anastomosis with arterial conduits. But the reason we ask that is because you could use a different arterial conduit. You could use 2 radials, 2 IMAs, an IMA and a radial. So the IMA is sort of like it's sort of like breaking it down. We want to know exactly what IMAs you used. And then we also want to know how many of your distals were arterials, which can include the IMA, but it can include the radials too.
Yeah. And I think the reason the distal also, what about if you have to add on a piece of conduit to your, I don't know if that ever happens. Do you ever have to add on a piece of conduit to your internal mammary to make it reach?
Mm-hmm. Well, sometimes, yeah.
Yeah. So the vessel is going to act more like whatever the distal conduit is.
Mm-hmm.
So that's why we collect it as well.
Right.
That's really good information. Thanks. Chris is asking if we could discuss, and I think, Selena, you asked if I could read the time the question was asked. I hope I understood right. So this is a question at 2:48 from Chris. It says, can we discuss the rate? And I don't know if your time's showing up Eastern or different your time according to your time zone, but 2:48 Central Time. Chris said, can we discuss the rate of stroke and mediastinitis reported in the IQVIA report in the participant dashboard? So I can't do that right now because we just have a few minutes, but I can, I sent your question that you had emailed over to IQVIA and they'll be reaching out to you. You have to pay attention to what's used in parent-child relationships, what's used for the denominator for reporting out those variables. I'm sorry, I can't get more into it right now, Chris. Next question is, can you clarify, this is at 2:50 p.m. Can you clarify normal morphology reporting on echoes regarding valves. Can this be marked as no for regurg only, or can it also be used for no stenosis?
I'm here. I'm just thinking.
Okay.
Because normal, I'm trying to figure out on the data collection form where I want to see. Let me pull this up so I can see how it's laid out in here, because I think you have to answer. Yeah, so you have to answer aortic valve disease. Okay, so you've got aortic regurgitation, you've got aortic stenosis, and you've got aortic valve disease. Okay, so normal morphology doesn't really, I mean, it just basically tells me that it looks normal. It doesn't really talk about, whether it's functioning normally. We do have a statement in the training manual that I'm trying to think of the exact wording, but we do have a statement that if it states it has normal structure and function, that you can use that and say no to regurg and stenosis. But just normal morphology, I don't think I would go with that.
No, I
However,
agree. I think that's the shape of the valve.
yeah, it's the shape of the valve. It doesn't talk about the function. However, we also have a statement in the training manual, and I'm looking for it because I hate to misstate. I hate to misstate things, especially in front of this audience, because then they'll send me 50,000 FAQs. I love you guys for it, but I don't want to
I
mistake.
just want to make sure they're paying attention, Melinda. That's
I
good.
know.
That's why we do this. Yeah. I'll let you look that up, and then I'm going to
look it up. I'm trying to find the exact number.
That's okay. We'll go to the next one. It says, if we have a new employee and we update the contact agreement, do we need to do anything different to get them access to IQVIA? No, Addie will update that in the system, and then IQVIA generates the login and password information. It might take a few days to get that, so it will be sent. This was the question at 2:54 p.m. It will be sent. If you don't have it in a week, then reach out and we'll be able to check with IQVIA, but usually they get that done pretty quickly.
Okay, I found it. So
quick.
It was an update in September 2020. So it says for pre-op valve regurgitation and stenosis, you got these parent fields, 1585, 1600, 1679, 1690, 1774, 1776, 1812, 1822. There are only yes or no answers. You can just go to 1585. These are yes or no answers. So if you got no documentation of any regurgitation or stenosis in your medical record, then code no. Don't open up the child fields and put not documented. Just code no. You've got no documentation at all of stenosis or regurgitation.
The regurgitation not documented for 1590, that's related to a statement that might be in the reports that says aortic valve regurgitation present, but where they don't quantify it.
Right.
Okay. Thanks. All right. Catherine says at 2:51. Oh, I got to get going, everybody. This is going to be my last one. I'm really sorry. If you have any specific questions that Melinda or I can help with, just feel free to email them to me. Can we get a specific report for the mortality thresholds and the NQF thresholds, especially for the FY data? The missing fields report is broken down by year and version, so it's hard to get a good sense of where we are on the threshold. Let me look into that, because I think there's a better way to use some of the reports that we have available, and we'll talk about it more on one of the upcoming calls. But Catherine, if you could please email this to me so I can check into it with IQVIA and make sure we get a good answer. We can present something good on that. Okay, I'm really sorry, everybody, but we have to get going because I have another call 2 minutes ago. And I just want to say, Melinda, thank you. You did an awesome job today, and really appreciate all the time and effort that you put into the database and the training manual for helping everybody do their job a little bit easier, I hope.
Thank you.
Yeah, thank you. And I hope everybody has a great day. We'll talk again soon, and please reach out if you have any questions. Thanks everybody for joining, and take care. Bye.
All right. Bye, everybody.